In this presentation, we'll be talking about perfusion indicators, and the outline of the talk will be first describe the oxygen delivery, and then we see how we use the Fick equation to measure the oxygen consumption and cardiac output. Then we'll detail on the use of mixed venous O2 saturation as an indirect indicator of oxygen consumption. And then we'll see how we can use the central venous O2 saturation as an alternative measurement for the oxygen consumption instead of the mixed venous O2 saturation that requires pulmonary artery catheter placement. And then we'll touch briefly on the veno-arterial CO2 gap before we finish with looking at the lactic acid as an indicator of perfusion. So the three main indicators are number one, lactic acid, especially with serial readings as an indicator of the anaerobic metabolism at the tissue level. The central venous saturation as an indicator of the oxygen consumption at the tissue level, and then the difference between the venous and arterial CO2 pressure, which is the gap, as an indicator of tissue perfusion and cardiac output state. And oxygen delivery is calculated with the formula of cardiac output multiplied by the arterial oxygen content. And we can look at the cardiac output as the vehicle and its speed, and then whatever load this vehicle carries would be the oxygen content. And there are few basic equations that you need to know, essentially those equations for the oxygen delivery, the oxygen consumption, and then the oxygen extraction ratio, with a simplified equation that uses the difference between oxygen saturation at the arterial side and the venous side. The Fick equation was described by Adolf Fick in 1870, and essentially look at the flow in any organ based on the concentration of the indicators between the arterial system and the venous system. So the indicator here is the oxygen, and then if we know the arterial oxygen content and we know the venous oxygen content, we can get the difference between the arterial content and the venous content, multiply it by the cardiac output to get the oxygen consumption. And in any hemodynamic assessment condition, you need to understand the oxygenation status in the body. And in order to understand the oxygenation, you need to calculate the oxygen delivery. The oxygen delivery is calculated based on the arterial content of the oxygen multiplied by the cardiac output. And the arterial content of oxygen is dependent on the amount of oxygen that is carried on the hemoglobin plus the amount of oxygen that is dissolved in the plasma or in the blood. So each 1 gram of hemoglobin carries 1.34. You can see in some references 1.39 of oxygen. And then you need to see how much of this hemoglobin is saturated. So you multiply it by the arterial saturation from the blood gases. And then, as I said, the second part would be the dissolved. This is a minute amount. You get the arterial oxygen pressure multiplied by 0.003, and this can be neglected. And then the third component would be the cardiac output that determines the oxygen delivery. and multiply the arterial oxygen content by the cardiac output, you get the amount of oxygen that is delivered at the tissue level. Now you need to know the amount that is used by the tissue or the tissue demand, and you can use the Fick equation here by since you know the difference or the arterial content of the oxygen and the venous content of the oxygen. You can subtract venous from arterial, multiply by the cardiac output, you get the oxygen consumption. And then if you relay the oxygen consumption to the oxygen delivery, you get the oxygen extraction ratio. And you can get information about the oxygen extraction ratio indirectly by measuring the mixed venous O2 saturation that requires placement of pulmonary artery catheter. We're going to just rearrange the Fick equation in a way we can make things simple, and I'm not going to go with the details of this rearrangement. You can find it in any textbooks, in any textbook that is describing this rearrangement, and do some rearrangement on both sides where you can simplify things and get a formula that is easy to be utilized at the bedside, and which is the mixed venous O2 saturation would equal 1 minus the oxygen extraction ratio. And we're assuming that the arterial oxygen saturation is above 90%, so we can utilize it in a way that mixed venous saturation would be 1 minus the oxygen extraction ratio. And since we have the ability to measure the mixed venous O2 saturation, and we know the determinants of this mixed venous saturation, which are mainly the arterial oxygen saturation, the hemoglobin, the cardiac output, in addition to the oxygen consumption. Those would determine the mixed venous O2 saturation. We can put the cardiac output, hemoglobin, and O2 saturation together because this is oxygen delivery and this is oxygen consumption. So the relationship between mixed venous O2 saturation would be directly with the oxygen delivery and indirectly with the oxygen consumption. And then if you have the value of the mixed venous O2 saturation, and you know that this value is related to number 1 oxygen delivery and number 2 oxygen consumption, you can make a differential diagnosis based on the value of the mixed venous saturation. So if the mixed venous saturation was low, this may be related to either a decrease in the cardiac in the oxygen delivery or an increase in the oxygen consumption. So the oxygen delivery can be decreased in any of the conditions that would affect the determinants of oxygen delivery, mainly the cardiac output, the hemoglobin, and the saturation. So you can see here if the hemoglobin is low, severe anemia can decrease can decrease oxygen delivery, and then mixed venous O2 saturation. In bleeding, similarly with the decreased hemoglobin, in hypovolemia and bleeding with the decreased cardiac output, or in any condition that can decrease the cardiac output, but also in severe hypoxemia, they can decrease the oxygen saturation of the on the arterial side. The other differential diagnosis would be an increased oxygen consumption. That means an increased tissue metabolism. This can happen with sepsis and fever, or with the agitation, shivering, seizure, the contraction of the muscles that can utilize more oxygen in addition to pain. Now, on the other side, if the mixed venous saturation was high, this could be related to either increased oxygen delivery, as it might happen with condition of high hemoglobin, cases of hyperoxia or fluid resuscitation, or the use of inotropes such as dopamine, and could be secondary to decreased oxygen consumption. This can happen with conditions that the muscles are not contracting, such as paralysis or sedation, analgesia at the same time. If the temperature is low in cases of hypothermia, or if we are shunting the blood from the arterial side to the venous side without using the oxygen because of inability of the tissue to take the oxygen. This can happen in cases of poisoning, the cyanide poisoning, or cases of septic shock or refractory septic shock. There's a relationship, as it's been indicated previously, between the oxygen delivery and the oxygen consumption or extraction. This relationship takes close to a straight line initially because of too much oxygen is delivered. The tissue will just utilize whatever is needed at the tissue level. But it gets to a critical point where after that there's not much oxygen is delivered, and the tissue will utilize all the oxygen that is delivered. The extraction ratio will be close to 100%, or there is a one-to-one relationship between the oxygen delivery and the oxygen extraction. And this has actually been described in multiple studies. You can see here the oxygen delivery up to till a critical point, where below this the oxygen consumption will go down. At the same time, the lactic acid depicted on this axis here, at this critical point, we start seeing the anaerobic metabolism and the increase in the lactic acid in the blood. And we should know also that in septic patients, this curve is shifted to the right and slightly up. So we can see this critical point at earlier stage than what it is in normal conditions. However, the mixed venous saturation requires pulmonary catheter to be placed in order to measure it. So can we use the central venous oxygen saturation from the central venous catheter as an alternative? Well, the answer is yes, and we have enough studies to support the utilization of central venous oxygen saturation instead of the mixed venous oxygen saturation. So the mixed venous oxygen saturation is at the pulmonary artery level, where the blood from the upper body part, brain and neck, is mixed with the blood coming from the lower body parts through the inferior vena cava, in addition to the blood that is coming back from the heart through the coronary sinus. When everything mixed together, if we measure it at the level of the arterial, the pulmonary artery, at that time it gives me an idea about the mixed venous oxygen saturation. Now, if we use the central line instead, so at that time we need to see whether they correlate with each other or not. And based on those different studies from 1982 all the way to 2010, you can see that we have good support that we can use the central venous oxygen saturation as an alternative to the mixed venous oxygen saturation. In this study, this is an experimental study in 22 dogs. You can see different conditions that they applied to the dog, and they monitored the mixed venous saturation in blue and the central venous saturation in red. You can see that there's a slight difference between the two, between 7 to 10%. However, they correlate with each other. You can see that they go down together when the dog is subject to bleeding, and then when the dog is given volume therapy, both improved at the same time. You can see still the difference between the two. And in different conditions, such as hypoxia, normoxia, or hyperoxia, they correlated with each other. And then if you plot the mixed venous saturation with the central venous saturation in this study, they got a linear relationship and very good correlation between the two. So we can utilize the central venous oxygen saturation instead of the mixed venous oxygen saturation, and the differential diagnosis would be the same. You have conditions where the central venous saturation is low, secondary to decreased oxygen delivery or increased oxygen consumption. When it is high, this would be secondary to increased oxygen delivery or decreased oxygen consumption. As I mentioned, there's a difference between the mixed venous O2 saturation and the central venous oxygen saturation, which is usually between 7 to 10%. There are some limitations and pitfalls of the central venous oxygen. It really depends on the location of the tip of the central line. So you need to be in the right atrium, close to the coronary sinus, to be able to measure the oxygen saturation that is mixing the blood returned from the coronaries with the blood coming from the IVC and the blood coming from the superior vena cava. So on the chest X-ray, there's a sweet spot that you need to see in order to determine whether I can use the central venous saturation instead of the mixed venous saturation. This sweet spot is actually in the area that is outlined between the conjunction of the vena cava, the superior vena cava with the atrium, and the costophrenic angle. So if your catheter is in this place here, you may rely on the central venous saturation in order to get an idea about the oxygen consumption at the tissue level. You can see the coronary sinus here and the blood coming from this sinus here, in addition to the IVC and superior vena cava. If your catheter is in this area here, it would be measuring the blood where it is. It can be used instead of the mixed venous. The measurement is if you're not mixing the blood well, so it may not indicate that, especially if you have myocardial infarction, for example, if there's an increase in any or if there's a change in the oxygen consumption in the myocardium, you may not be able to pick it up with the central venous oxygen saturation. In other words, the central venous oxygen saturation is a reflector of global perfusion, number one, and you may have a regional hyperperfusion that you may not be able to detect. And as I stated before, it depends on whether you're able to measure the blood coming from the coronary sinus or not. So moving to the venous arterial CO2 gap, we know that CO2 is 20 times more diffusible than oxygen, which makes it a good indicator of tissue hypoxia, even in the states of poor perfusion. And this is trying to overcome the limitation of Fick equation by the oxygen consumption. If we utilize the CO2 production, it may make things simpler. And what we're doing here is we're just replacing the oxygen content, the arterial oxygen content, and the venous oxygen content by the CO2 content. So if you multiply the cardiac output by the venous oxygen venous CO2 content minus the arterial CO2 content, you get the CO2 production here, not the consumption, it's the production. And you can rearrange this, and the cardiac output would be the CO2 production, I'm sorry, divided by the difference between the venous and the artery of the CO2 content. And this is how the CO2 veno-arterial gradient or gap was born. And essentially, it is related to two things. So when we see the difference between the venous and arterial CO2 in terms of pressure, usually it should be less than 6 millimeter mercury. It is directly related to the CO2 production and indirectly related to the cardiac output. And it's mainly used as an indicator of adequacy of cardiac output. The gradient is usually less than 6, between 2 and 5 millimeter mercury, and it gives you an idea. If it is higher than 6 millimeter mercury, it may be because of low cardiac output, which is the global flow, or poor local flow state in cases of stagnation. And it is also a prognostic indicator. You can see in this study that if you measure the CO2 gap at time 0 and 6 hours later, and your gap was low at the beginning, remained low, the outcome is good. If the gap was high at the beginning but normalized, the outcome is good, is not as good as when it was low and low. And then if you have patients with gap starting as low and then increased, or started at high and then increased within 6 hours, that is an indication of poor outcome. And the lactic acid is the indicator that we most likely use in terms of assessment of perfusion and metabolic rate or anaerobic metabolism in the body. In order to understand this, we need to understand the glucose metabolism. Of course, the glucose is converted to pyruvic acid, and the pyruvic acid is under oxidative phosphorylation, is converted into acetyl coenzyme A under the effect of pyruvic dehydrogenase, and then goes into the Krebs cycle and produces 36 ATPs. The byproduct would be water and CO2. Now, if we do not have enough oxygen, if we're not operating under oxidative phosphorylation conditions, at that time the pyruvic acid will be converted to lactic acid under the effect of lactic dehydrogenase. And then we have the Cori cycle, where the lactate can be converted back to glucose in the liver. You can see with the use of ATP, the lactate can be converted back to pyruvic acid and then to glucose, and this is the process of gluconeogenesis. So if we have someone who's exercising, the muscles will utilize glucose into pyruvic acid, and if we lack the oxygen, it will be converted to lactic acid. This lactic acid goes to the liver and is converted back to pyruvic acid and back to glucose, and this is the gluconeogenesis that we have in the body. Now, the lactic acid is a prognostic indicator also, and you can see in this study that is published 1996 that the outcome is better, survival rate is better when the arterial blood lactic acid level was less than 3.5 compared to those patients who had lactic acid level 3.5 or above. Survival rate at 10 days was 30% when lactic acid was more equal or more than 3.5 millimole per liter. It can also give you an idea whether you are dealing with occult shock or not. You can see here that patients who have lactic acid elevation above 2 may not necessarily have hypotension. So you can see that the systolic blood pressure here is more than 90. However, if you take a look on the mortality, you can see the mortality is higher in those patients who have systolic blood pressure above 90 and lactic acidosis, indicating that those patients are in shock. However, the systolic blood pressure is more than 90, maybe relative to the baseline, there's a drop in the systolic blood pressure. So you can use lactic acid as an indicator that your patient is not perfusing well, but you need to rule out any other condition that can cause lactic acidosis. Also, the clearance of the lactic acid is so important. That's why we monitor the lactic acid clearance. So we do the first measurement of lactic acid, and then in 3 to 4 hours we get another measurement to see whether we cleared the lactic acid. In those patients who cleared the lactic acid in less than 10%, had worse outcome compared to those patients who cleared the lactic acid at a rate more than 10%. And you can see the difference between the two groups of patients. This is a study that was published in 2004. As I mentioned, you need to rule out other causes of high lactate in the blood. And we have two types of high lactic acid. We have type A, which indicates that it is hypoperfusion condition at the level of the body, or at certain either globally or locally. So that is what you need to rule out first. Do we have cellular anoxia? Do we have a condition that is preventing the pyruvic acid to go into Krebs cycle? If you rule out any global or local hypoperfusion or anoxia, at that time you go and determine whether you have type B lactic acidosis. And the two main conditions or categories that will cause elevation of lactic acid without hypoperfusion is number one, stimulation of glycolysis, and number two, impaired lactate clearance. So the type A hyperlactatemia is related to the loss of oxidative phosphorylation of pyruvate. This can happen in all kinds of shocks, whether it is septic shock, hypovolemic shock, or cardiogenic shock. It can happen in any global hypoxia at the level of the tissue, whether this is caused by CO poisoning, for example, or by severe hypoxic respiratory failure, where we don't have enough oxygen at the tissue level. So this would be global. Now, also severe anemia can cause global, it's a global condition. It can cause an increase in lactic acidosis. Now you have regional conditions where you have ischemia, but it is involving large organs such as a limb or the gut with bowel ischemia. You can have an elevation of the lactic acid because of hyperperfusion to that individual organ. If you rule out hyperperfusion, at that time you need to go with the differential diagnosis of what is causing the hyperlactatemia. It could be because of glycolysis stimulation. This can happen with any medication that has a beta-2 stimulation effect, such as the catecholamines. So if in patients who are on epinephrine, you will see that those patients may have, as we talked in previous talk, may have increased lactic acid. Similarly, patients who are taking cocaine can increase their lactic acid. Now, if you have a malignancy or hypermetabolism of the cells, you can produce more lactic acid and can be elevated in different malignant condition such as B-cell lymphoma. The other category would be impaired lactic clearance that could be caused by impaired gluconeogenesis secondary to utilization of ethanol or some medications such as metformin. You can have impaired lactic clearance because of impaired Cori cycle at the liver level. In patients with hepatic failure, they do not convert the lactate back to glucose, and lactic can be elevated. You can have elevation of lactic acid also in patients with renal failure, but minimally. In patients with pyruvic dehydrogenase problems such as inhibition through the thiamine deficiency or through inborn error in the enzyme itself, you can see elevation of lactic acid. Finally, mitochondrial toxicity, such as what happens with the heart drugs that you can use in AIDS patients such as AZT. Finally, you need to know that macrocirculation may not give you a clear idea at what is happening at the microcirculation. And it seems that microcirculation may not be sufficient in terms of the assessment to give you a clear idea at what's happening in the microcirculation. So we need to gather all the clinical information and the parameters that we have in order to get a better idea about what's happening at the microcirculation. The prognosis remains poor if the microcirculation was not corrected. So yes, we optimize the systemic macrocirculation that we can manipulate and monitor the numbers. However, we may not be able to maximize the microcirculation. There is no specific therapeutic approach so far that is available to target microcirculation. In conclusion, we talked about how mixed venous O2 saturation is a good indicator of global tissue perfusion, as it gives an idea about the oxygen consumption. And then we talked about using central venous oxygen saturation as an alternative to mixed venous O2 saturation. And then, of course, we mentioned some limitations in relation to the central venous O2 saturation, especially with the location of the tip of the catheter, of the central line catheter. And then we talked about the CO2 veno-arterial gap as an indicator of condition of cardiac output, especially if it is low cardiac output. And then we looked at the lactic acid as a great indicator of tissue hypoperfusion, but in the right context. And other causes of high lactic acid must not be missed. If tissue perfusion is adequate, no need for major interventions. With this, I would stop here, and hopefully we can see some cases in the next presentation where we can determine the condition of perfusion in individual patients. Thank you very much.